We're going to get started. So welcome everyone to the California ACC Fit Networking and Career Development event. I'm Megan Pelter.
And I'm Pani Vafai.
And we are the Southern and Northern California ACC Fit chairs. We are thrilled that you could join us today for what will be an exciting and informative session.
So before we begin, we'd like to take a few seconds to thank our wonderful esteemed panelists who took time out of their extremely busy schedules to join us tonight. We'd also like to thank the California ACC Board and Executive Committee, especially its President, Dr. Jamal Rana, Vice President, Dr. Anthony Hilliard, and CEO Leanna Collins for their unwavering support and enthusiasm. This program would certainly not be possible without their tremendous leadership and guidance. We'd also like to thank our FIT committee for their dedication and hard work in recruiting all of our wonderful speakers tonight and organizing this event that will hopefully serve as a very valuable resource for fellows and other trainings considering cardiology.
As a reminder for today, the format of the session will be as follows. We will first start by having our panelists introduce themselves. We will then discuss several pre-selected questions before opening it up to the audience for further questions and answers. If you do have any questions, please submit them to the chat box. Pani and I will then present them to the panelists. Please remember to remain muted for the course of the event. If you have a question you would like to verbally ask, then please raise your hand and we will unmute you.
So again, this session will be recorded and available on the California ACC website for further viewing. So with that, let's go ahead and get started. So first off, we'll have our panelists give us a 3 to 5 minute introduction, each outlining their background, training, career, and journey within the field of cardiology. So we'll have Dr. Aditya Bharadwaj get us kick-started tonight.
Great, thank you guys. First of all, it's great to be here today and thanks for having me. So I am an associate professor of medicine. I'm an interventional cardiologist here at Loma Linda University in Southern California. I also am the director of the complex coronary interventional program here. And like I'm going to talk about in a little bit, that sort of has been my niche over the last 5 years of my practice. In addition, I'm also the program director for the Interventional Cardiology Fellowship here. And so it's been a great journey, you know, as an early career cardiologist. When I started here at Loma Linda, it was almost like coming back home for me because I did my general cardiology fellowship here. And then I went off to New York City to do a year of interventions at Mount Sinai in New York City. And then I came right back here to start as an attending. And honestly, I could not have asked for a better place to start my career. I think it's been a great mix of clinical practice, academia, teaching, research, sort of all the things that I wanted for myself starting off as an early career cardiologist in academic cardiology. And like I previously mentioned, my niche has been high-risk coronary interventions and cardiogenic shock. It's an area of interventional cardiology that I'm really passionate about. I think just because of the adrenaline rush and the cool technology that we have, not to forget, of course, the big difference that we can make to patients, their lives and their symptoms. It's also an exciting niche of interventional cardiology because it's just bursting with all these new trials coming out. In fact, what makes it more exciting is that currently there's not a lot of data to back a lot of what we do, especially in high-risk interventions and cardiogenic shock. So we are in this phase, as far as this subspecialty is concerned, we're in this phase where we are gathering data, where we're building out these randomized controlled trials, enrolling patients, and sort of really figuring out what's the best way to treat these really complex patients. So it's an honor and a privilege to be in this place at this time, and you know, great to see you all, and look forward to questions.
Fantastic. Thank you so much. Dr. Beyer, if you don't mind introducing yourself.
Sure. Well, thank you for having me. Also, I'm very honored to be among these wonderful people and colleagues. And thank you for having me, of course. My name is Anna Beyer. I'm an interventional cardiologist. I also have a pretty large general cardiology practice that I enjoy. I'm part of UCSF cardiology faculty. I'm associate professor at UCSF. My first 10 years of training, I worked at a private practice at CPMC, and about 2 years ago, I joined UCSF, sort of in the search of more academic path. We have a smaller sort of sub-UCSF group that harmoniously blends, I would say, the community and academic practices at both places, at two institutions, and we are both UCSF and CPMC. We try to do our best in teaching and do our procedures at both institutions. I'm faculty at both places, cardiology fellowship programs, which I enjoy. And since I did my general cardiology training at CPMC and my interventional training at UCSF, I sort of love the way that it's now reflecting in how I practice. So that's where I am today.
Wonderful, thank you. Next, we'll have Dr. Cingolani.
Hi, well, it's great to be here. Thank you for having me. My name is Eugenio Cingolani. I was born and raised in Argentina, where I went to med school before coming to the US, where I did my training in research, followed by internal medicine in Johns Hopkins in Baltimore. After that, I moved to the West Coast, where I trained in general cardiology, following by clinical EP in Cedars-Sinai in LA. And after that, I was lucky to stay as faculty, where I divide my time between patient care, research, and teaching. And it's great to be here, and I hope we will have great discussions.
Excellent. Thank you so much. And next, Dr. Han, if you don't mind introducing yourself.
Sure. Hi, everybody. It's great to be here. My name is Janet Han. I am currently an associate professor of medicine at UCLA. I'm an interventional cardiac electrophysiologist by trade. I actually started in this business thinking I was going to be an ophthalmologist. And so if anyone has any questions about changing career paths, I'm here for you, for sure. So I ended up leaving ophthalmology and completing internal medicine at Cedars, where Eugenio was. And then left ophthalmology specifically to go into interventional cardiology. And then by the time I was done with my cardiology fellowship at the VA, I was like, I'm done, I'm so tired. Then I was like, I was just gonna get a job, but then EP sort of fell into my lap because there happened to be an opening, and I loved being in the EP lab. I loved all the surgical stuff. I loved all the intellectual stimulation. And so took the position just on a whim, and the rest is history. So I look forward to an awesome discussion tonight. Thanks for having me.
Thank you so much. That's wonderful. Next, we'll have Dr. Jason Hoff.
Yeah, good evening. Thank you for having me as well. I feel honored to be with all of you and help inform the younger generation, kind of make decisions and choose their career paths. So I'm originally from Loma Linda, did my medical school at Loma Linda. And I also flirted with ophthalmology briefly, first year of medical school, and but eventually, saw the light and switched to cardiology. And so then I did residency over at Beyer College of Medicine in Houston, Texas, and then came back to Loma Linda to be closer to family. Did the rest of my training at Loma Linda. Honored to stay on as faculty with Aditya Bharadwaj, and he was one of that helped train me during my interventional cardiology years. So, happy to work with him as colleagues now going forward. In terms of area interventional cardiology by trade, also enjoy general cardiology and prevention, but specifically procedural focus. I've been involved with the structural procedures involving TAVR, MitraClip, PFO, AST closure at Loma Linda, and so I've been honored to be a part of that. And so, looking forward to answering any questions. I think cardiology is so broad and ripe with, opportunities in every different angle and niche that you want to focus on. So I'm excited to talk about it.
Excellent. Thank you so much for that. Next, we have Dr. Richard Hongo.
Hi, Rick Hongo. So I'm an electrophysiologist here at CPMC, same with as Anna. And CPMC is a quaternary referral center for the Sutter Health Network here in Northern Cal. It's about a 24, 25 acute hospital network. And over the last several years, it's really become the referral center for the network. And so I've been fortunate to have a practice here that's 100% EP. I think we'll do some discussion, I'm sure, about electrophysiology and different types of EP practices that one can have. But I've been fortunate to have an EP practice that really focuses on complex ablation, complex device management is something that the hospital really supports, not just in terms of facilities and equipment, but also in terms of referral. My training has pretty much been based in California. I did my, I got my MD degree at Loma Linda and did my CPMC cardiology fellowship and then went to UCSF for my EP. I pretty much wanted to do EP probably my second year. Mel Scheinman, who is at UCSF, would come every year to give us a grand rounds. And one of those grand rounds inspired me, really pulled me away from intervention. Initially, the first year I was thinking intervention. But EP was very enthralling based on that discussion and that talk. And I did some research with him during my third year and then stayed on there for 2 years. And I was very fortunate to come back to CPMC. Been really involved in the cardiology fellowship program that's here. And the last, I would say 5-6 years, I've been in the role of a director here, despite being EP, director of a general cardiology fellowship program. And it's a lot of my time is dedicated to teaching, mentoring, also program development. So I'm sure there'll be discussions about, you know, teaching, mentoring, and different types of academic settings fit into what you're looking for in your career. And but I've myself found a great balance of both clinical work as well as teaching without having to write grants and so forth. So that's a key part of why I love being here. But very, very much looking forward to the discussion that we'll have. Thank you very much for inviting me.
Wonderful. Thank you so much, Dr. Hongo. Next, we'll have Dr. Gopi Manthripragada.
Hi, everybody. Thank you, Pani, and the ACC FIT for inviting me to join this committee. I was a training nomad. I'm a Southern California native who did medical school at Northwestern. Then I did my residency training at Georgetown, went to Pitt for cardiology fellowship, came back home to UCLA for an interventional fellowship, and then went to Mass General for a vascular medicine fellowship. And then returned to UCLA to join faculty, where I was for 5 years. I was in a satellite practice off of the main campus. And so I was sort of an 80% generalist, 20% interventionalist. Really enjoyed my time there, actually. Was also the assistant program director for the interventional fellowship program. And so I was very intimately involved in teaching, not quite so much research. And then 5 years in, I transitioned to Kaiser Permanente in San Francisco, where I'm now primarily an interventional cardiologist. So I'm 100% interventional. And I also love my job here. So I can talk a little bit to, I can speak a little bit to both sort of a academic / private practice setting, as well as a large healthcare system practice, albeit differently in terms of time spent with interventional versus not. I don't really do much vascular anymore, but I'm part of the SCI committee in vascular medicine and vascular interventions. And I, like some of our panel members, I also specialize in complex heart interventions and CTOs.
Excellent. Thank you very much. Dr. Park, if you don't mind introducing yourself.
Sure. Hi, I'm Shirley Park. I'm also an electrophysiologist. It's interesting, this ophthalmology EP connection. I never considered it, but my mom wanted me to go to ophthalmology. But I was actually EP from the start, like from med school, I would say. I was at NYU med school. I just love the fact that it was kind of one of the few things in medicine that was fairly kind of logical, where you can figure something out as opposed to a hand wavy kind of thing. And so, yeah, I was pretty much EP all through med school. I went to Stanford. I went over to Stanford for a long time for medicine, for cardiology, for EP. Then I stayed at Stanford as faculty for about 5 years. And then the last 2 years of those, I was part-time VA as well. So, and then for the last 3 years, I came over to Kaiser. So I'm actually at Kaiser Santa Clara, Northern California Kaiser. And so I can also speak to academic, kind of private practice model, Kaiser, also VA, if anybody is interested, which is a little bit unique. It's kind of like an in-between between Stanford and Kaiser. Yeah, but I've never regretted my decision to do EP. I feel like it's the perfect field for me. So, yeah.
Wonderful. Thank you, Dr. Park. And lastly, we'll have Dr. Raul Bharadwaj.
Hi, I'm driving right now, sorry, so I can't go on the video. I am a Southern California native. I'm working at Loma Linda University, which I've already heard about from several other panelists. I did med school at UCLA, and I did most of my cardiology. I did my general medicine and cardiology training at UC Irvine, and I did EP fellowship at Mount Sinai in New York. And straight out of fellowship, I came back to California and started at Loma Linda, where I've been for the last 5 years. I was drawn to EP probably before I started my cardiology fellowship. I took a year off between medicine and cardiology. And I basically was studying EKGs, trying to learn mechanisms of arrhythmia and all that. And it was really fascinating to me, just the physiology and the nitty gritty. And then in second year of cardiology fellowship, I kind of confirmed my decision. I was drawn to both interventional and EP. I knew I wanted to work with my hands, and I chose EP ultimately because I thought it kind of married my love for procedures, complex interventions with, and there was more variety in the types of procedures you can do, and there was a lot of physiology involved, which I found very, very fascinating. That's me.
Excellent. Well, thank you all very much for introducing yourselves. And as a reminder to our audience, we are going into the pre-selected questions. So Pani and I have 3 or 4 that we'll ask, groups of our panelists. But if you do have any questions, please feel free to write it in the chat box, either to Pani or myself or to everybody, and we'd be more than happy to answer them or to moderate them in the Q&A session afterwards. But let's first start off with the first question. So the question is, how did you solidify your interest in your field? And if you did have an additional niche, or you specialize in a certain procedure, or you just love doing the procedure, why is that? So let's first start off with Dr. Beyer, if we could.
Sure. So I think I wanted, when I went into cardiology, I wanted to do heart failure for the longest time. I actually did some training in heart failure, not ACGME, but like at San Francisco VA, and then a year in between cardiology fellowship and medicine. I did also heart failure fellowship. But during my second year, I'd say, of cardiology, when I was in the lab and felt a little bit more comfortable, I felt like, you kind of dream it all the time. You feel like you want to be there all the time. So it was more probably an obsession, and then it became sort of something that I just wanted to do and be there as much as I can. So, and it's all of us are drawn to it, but because of adrenaline, because of physiology, because you can solve a problem and make somebody feel better. So, and it's still there. The passion is still there. So I still love being in a lab, and that's, and I love doing complex procedures, and I, love anything that becomes more complex or starts off more complex. It's just thinking about trying to figure out how to solve a problem and solving it. So I'd say, you just know that you like it. I can't tell you that, and I've never looked back and thought that anything else can give me the same kind of satisfaction as intervention does. So.
Excellent. Thank you so much. Dr. Rahul Bharadwaj, same question.
Okay, yeah, so I started off my interest in EP from reading about it and just reading the papers, but what really got me more comfortable with the field and being more sure about my choice was going to various meetings. That includes like ACC, AHA. At the various conferences, they always have subspecialty sections, and I recall at ACC, there was even an opportunity to sit with mentors in EP, like, very highly regarded thought leaders that gave us their impression. And I found that to be very, very helpful. And going to actually industry events. So in EP, I think you have a lot of opportunity to go to various meetings held by the different device companies and so forth, where you could learn more about the field. I do believe that EP is a bit of a black box to most people in general cardiology fellowship. You get limited exposure. At least I had limited exposure to the complex procedures. So a lot of it had to be from these types of external sources. I also had just a couple of patients that were very sick at like, ECMO, and it was like epicardial, all kinds, and I'm really involved with those patients. And more certain this I can see myself doing. As far as the question goes about the procedures and what procedures we're drawn to, I think that kind of came more during EP fellowship. I able to see a lot of left atrial procedures. I enjoyed them, and I found myself in Watchmen, the epicardial, endocardial, and experience of terminating EP
Dr. Bharadwaj, I think, is in his way driving, so he might get lost or, off of Zoom, but we'll get him back as soon as possible, of course. But let's move on to Dr. Cingolani, if you don't mind answering the same question.
Yes, so to me, when I first started doing research, when I came to the US, I was exposed to basic techniques that involve electrophysiology. And I already had, a previous training back in Argentina of internal medicine, and always was fighting with myself between my heavy clinical training and background with my research ideas and physiology. And when I retrained in the US and I went into cardiology, I always found that EP was great because I could make up things very logically and use all the basic knowledge, and also use my skills as a clinician to help my patients. And I really loved the ability to be able to do real-time complex physiology when we were doing procedures, and be able to help patients and give them a solution. I think that's super important to me. And with the procedures, I really like complex diagnostics, but I really like those procedures that are curative for our patients. A good accessory tract where you do that ablation and the patient asks you when I have to see you again, and you just tell them never, you don't need a doctor anymore. To me, it's super gratifying for me, the ability to do that. And I don't think many fields have that, the ability to do a procedure that is literally curative for the patient. The patient does not need a physician anymore. Yeah.
Excellent. Thank you so much. Dr. Han, the same question.
So I kind of touched on it earlier that I sort of fell into EP. I think, I was really sort of in love with ophthalmology for a long time. Like in med school, I thought that would be the right thing because it was, nice fixed hours, and there's like surgery, and I loved surgery so much. And it was really a branching point because I loved medicine as well, the intellectual part of medicine. So it was really tough for me to pick the right specialty. So I did end up going into ophthalmology. And once I was there, the problem was right before I left for my ophthalmology residency, my transition year was at Santa Clara Valley Medical Center up north. And I did cardiology as my last rotation. And then I was like, oh my God, I've made like the hugest mistake in the whole entire universe. So I went to ophthalmology, and within the first 3 months, I'm like, you know what, this is not right for me at all. Because I saw someone in the cardiology rotation, one of the attendings, I went to the lab and saw them put a stent in someone, and they like, blood was restored and everything was, you know, wonderful. So then I, you know, again, left ophtho to come to Cedars and to do interventional cardiology, because I thought that was what I was going to do for sure. And I loved every single second that I was at Cedars. I did tons of cardiology, and again, really thought I would do interventional. Got into cardiology fellowship here at the VA, which I still am here. And you know, I did my EP rotation, and I think, you know, what ended up happening was there's so much surgery in EP as well, that I thought, oh my gosh, maybe this is really the right thing, because I even love, weirdly, even the sound of like hemostats closing. So I feel like love surgery so much, love procedures so much, but love cardiology. And so I love my EP rotation, but again, like I said, I was like kind of tired after I, you know, finished my fellowship, had the spot open. And I said, you know what, you might as well take it because it's not that easy to get. Took it. It was a year only at that time, and did my fellowship, and I loved it. I haven't looked back. So I have to say EP is really the perfect blend of intellectual medical stimulation and some procedures that are truly, truly surgical. So if anyone has that thing where they love both things, if you're a med student and you love surgery, but you love, you know, intellectual stimulation, EP is the bomb. So that's how I got to where I am.
Excellent. And last panelist for this question, Dr. Hoff.
Yeah, I'll start off by kind of saying what I tell a lot of med students, a lot of residents when they're, you know, talking about what they want to go into. Because as you can tell, I mean, even just within cardiology, each little niche, each little area has so many amazing aspects to it. So many things that if you scrubbed into one of our procedures, you'd be like, wow, this is amazing, right? So in terms of what you should decide, you should look at the stuff that maybe is considered the annoying parts of that specialty. And if you enjoy those annoying things, then that's probably the specialty for you, right? So, and also another piece of advice that I give is don't take other people's negative things that they say about a specialty to influence your own opinion. When I was a resident, I had an interventional cardiology fellow come up to me and was miserable. You know, so I was in the CCU and they came up to me and they're just like, you know, if you're thinking about going into cardiology, I would not recommend going into interventional cardiology if you want to have a family and if you want to have a life, which was a big deal for me because that was important. You know, fast forward. And so actually first year of cardiology fellowship, I was kind of the diehard EP fellow. So I, you know, dove, when I dive into something, I dive into like 100%. And that's really how you know if you like it or not, right? So you just get experience and, you know, see if you would enjoy doing this. And it was my wife who noticed, like, you know, I've noticed when you come home from EP rotations, you just seem tired and you don't really talk about it a lot. Like, but when you're on your cath lab rotations, I might come home late, you know, it's been a long day, you know, and stuff like that. And you're pumped, you know, you're excited. You know, that speaks a lot for, you know, ultimately what you should do. You know, you should be energized even on the worst days. You know, you come in for a shock case in the middle of the night, 12 a.m. to 4 a.m. You know, you're on, you know, clinic the next day, but you come home and you're energized. You know, you're like, you know, I'm excited about this. So, you know, those kind of little subtle things in terms of your personal journey is really what you should kind of pay attention to in terms of making your ultimate decision. You know, I mean, fast forward, I mean, you can have a life in interventional cardiology. I have 4 kids and, you know, and I see them and, you know, obviously, you know, you put them to bed and you may have to go in 1 or twice throughout the night, but at least they're sleeping and you kind of take that burden on yourself. Yeah, so in terms of niche procedures, like I said, everyone's going to have ultimately, there are areas that they like. My favorite thing is structural procedures. you know, I same things that you guys have said, enjoying stuff that where you can do something and make not just an immediate but long lasting impact on someone's life. Obviously structural procedures, you can do that. TAVR is probably the most glaring thing. I mean, you do one procedure and they go from, not a surgical candidate, or even if they were, but not a surgical candidate, and feeling very sick, to feeling great and, for a long time. So, I mean, there's those things in cardiology are very exciting.
Wonderful. Thank you so much. We're going to go ahead and move on to our next question. And the question is, how did you all choose your current practice setting, whether it's an academic, private, or a managed care setting? And as many of you have experience within various practice settings throughout your journey, if you could elaborate on your experiences and let us know how you ultimately ended up deciding on the current practice setting that you're in. So we're going to go ahead and start with Dr. Richard Hongo.
So when I finished EP at UCSF, I knew I wanted to come back to CPMC to practice, mainly because, doing training there, I had seen an environment where you could do clinical practice and be in private practice and yet be really involved with teaching, mentoring, whether it be medical students, internal medicine residency, but also fellowship. So I knew kind of right away that's what I wanted to do. So while I was up at UCSF, I would actually come down and almost have monthly meetings with the different attendings here and have lunch and kind of keep a pulse of what was going on, because I really was lobbying to come back. And the opportunity opened up, and I was able to join a private practice setting. So I guess this is part of the question that was asked. So when I first started, there were two large cardiology practices, one up in Marin, which is north of San Francisco, and then the CPMC private practice group. They collectively joined together to recruit and start electrophysiology. So most of EP in San Francisco at the time was out of UC, but CPMC was wanting to start that. And so they recruited Andrea and Natalia to come once a month and spend a week with their medical group, basically. And in that setting, I recruited me and Steve Howe, the two of us that basically just came out of practice. So it was within that environment that we practiced. And I'm sure there will be questions later on about mentoring and so forth, but I did find it very important for my career to be under mentorship from, experienced electrophysiologists, in this case, from Andrea. And in that setting, we grew that practice that was, between the two institutions, but essentially gravitated towards CPMC as being a more central referral center. And then at some point, Steve Howe and I, my partner and I, we kind of sensed that the direction in California was really away from private practice and really towards larger groups, foundation, university practices, and so forth, especially up here in Northern Cal. And we actually made the decision to leave. And I still remember the day we had to go to our partners and announce it. It was a very black day for the two of us, but it was a very important decision for us, and the way things really transpired over the next several years, the practices here in Northern California really fell into, aligning with larger groups. And so right now we joined the foundation, so Sutter Foundation Cardiology Group. And in that setting, we're still a medical group, but affiliated with the foundation here. And, one of the things I think that are important when you're looking for practices, whether it be private practice or in a larger setting, is really to early on make the effort to be involved in how that practice operates. And so a lot of what the two of us have been able to do is help influence how our practice integrates within those groups. And we've been able to maintain a certain amount of independence and influence within larger organizations, which really especially here in California, is the way a lot of practices are going, is larger organizational practices. For me, it was very important, first and foremost, to be at CPMC, to be able to teach and to be involved in that environment. And so, joining the foundation, coming primarily here, was the right decision for us and for me. And one thing I can say is, in today's world, you do have to keep an eye on how things are changing, because one of the constants, I think, is that things will change. There's no way to predict at the beginning of my practice where I would be now. And I think in the next 10 years, things will be different as well. And I think it is important to be willing, actually, to make the change when necessary. That was a big part of the story of how my practice has changed and developed over time.
Wonderful, thank you. Same question, Dr. Manthripragada.
Thanks, Bonnie. So I wholeheartedly agree with what Rick said. My initial instinct after training was that I wanted to join a larger group practice, because post-Obamacare, it seemed that the private practice models, they really weren't doing as well, and there was mass consolidation happening where they were either becoming hospital affiliated or just coalescing with the larger healthcare system. So for me, it wasn't too hard of a decision, because I was going back to home. I was going back home to UCLA, and I was joining a practice that I knew quite well from my training. I will say that there's definitely a post-training practice potential for a mismatch between your expectations and the reality that you face. As a matter of fact, I remember being in a FIT meeting soon after training where they mentioned a statistic that blew my mind. They said that 80% of new grads at the time switched practices within 2 years of practice, which is mind-boggling. So I think that a lot of that speaks to what we expect as fellows compared to what we actually see in real life. And sometimes there can be disillusionment when we start a practice, because nobody really talks to you about billing and things like that you really nobody mentions it when you're in training, and it becomes a huge focus of practice. So within my practice, you just try to find ways to thrive, right? And find a niche for yourself. And so, I was giving talks to in public environments like nursing homes and things like that, just to sort of get my name out there and get people to recognize who I was, and then bring patients within my practice, while at the same time trying to grow develop myself as an interventional cardiologist. And, as a proceduralist, I think it's, it can be challenging to really hit the ground running out of training, because you have the jitters, you want to be perfect, and you're sort of not as confident as you should be. I think for most people, it takes 3 to 5 years to really grow into yourself, grow into your skin, and into confidence, and become a supremely talented, good operator. I think for other people, it could be a shorter amount of time, but for me, it took me like 5 years to get really confident, 3 to 5 years to get really confident. So my experience though was great, because I had mentors to guide me, and like Rick, I had a partner, Ravi Dave at UCLA, who's currently the program director, who's just an outstanding human being, wonderful man, and he was honestly the sole reason I joined the practice, because he's such a great human being who also is a great mentor. So, as Rick mentioned, mentorship is of critical importance, and so my advice would be, as a young trainee, unless you really want to be the person in a new practice where you're comfortable being a solo practitioner with all of the headaches that entails in terms of from a business standpoint, et cetera, you could go into middle of Alabama and have a thriving practice. But if you want to if you're a different type of mentality where you feel like you need mentorship, then a large group practice might be a better option for you. And picking a mentor is key. So for me, after 5 years at UCLA, I got a call from a friend who mentioned an opening at Kaiser San Francisco. And it goes to show how you just never know when the next door is going to open. And if you're a good human being and you're good to people around you, doors will open for you. And so that sort of happened to me. So I had a former colleague call me out of nowhere telling me about this opening at Kaiser San Francisco, and I really didn't think much about it, to be honest, but I came up for the interview. And at the time I was, as I mentioned earlier, I was primarily a general cardiologist who did interventions on the side. And I saw the opportunity to be 100% interventionalist, doing primarily interventions. And I jumped at the opportunity. And I will say that I feel incredibly fortunate. I have a fantastic job. I have fantastic work-life balance. And it speaks to one of our other panelists who mentioned work-life balance as an interventionalist. Yeah, don't let other people dissuade you. If you found your passion, you can find balance. That's on you. And so don't listen to people who say that interventional or EP is not the right job for you. I think you can totally have balance in invasive fields. And so currently, I'm 100% interventional. I've sort of used my prior training in vascular medicine as a segue into complex coronary interventions and CTO interventions. So I don't think that was a wasted skill set, even though I don't do much peripheral anymore. And I think it also, as you'll notice in your careers, it ends up meandering in ways that you cannot predict. And so the one good thing is that no training or learning will ever go to waste. And so whatever skill sets you learn, whatever people you meet, you just never know when that's going to come in handy down the line.
Wonderful. Thank you so much, Gopi. Next, we have Dr. Park.
Hi. So for me, out of EP fellowship, so I had known the chief of EP at Stanford ever since I was a resident. I started doing research with him. I knew him through cardiology. Everybody knew I was EP. And then in EP fellowship, he approached me and asked if I would be interested in staying on as clinical faculty. And so that's kind of how I got my foot in the door in academia. And it was kind of a nice, I had done research during fellowship, but I knew in my career I didn't necessarily want to pursue research because I was doing basic research, which as a proceduralist is really hard to maintain a successful basic science research career and be a good proceduralist because you really got to keep up your procedure skills. And so this was a clinical educator position, which was perfect because I love teaching and I loved working with the fellows. And so that's how I ended up staying at Stanford. And I was there full-time for 3 years. And then the thing is I got pregnant with my second child right at the beginning of starting attending at Stanford. And so, but the end of 2 years, I was so tired. And then this opportunity came up at the VA, Palo Alto, which is associated with Stanford, where prior to that, we had just been going over about like once a week to cover cases from Stanford to the VA. But they were looking for a full-time or relatively full-time EP there just for continuity of care. And so I kind of jumped at the opportunity just for work-life balance for me at that time. And it worked out great. So I ended up going sort of mostly, but still keeping part-time Stanford. So I went to the VA and I was so happy there for the first year because I had a much better work-life balance. And yet I still attended at Stanford occasionally. I still got to work with the fellows. Seemed like the best of both worlds. And after 1 year at the VA, I then got called, kind of cold call, just like Gopi, from a former fellow. There's a lot of cardiology fellows that I'm going to Kaiser, various Northern California Kaisers. And this is a Stanford cardiology and heart failure fellow who is now the assistant chief of cardiology at Kaiser Santa Clara, who called me, and I thought he was calling like to discuss a patient, like a VA patient that ended up at Kaiser or something. But it was that, one of the EPs was retiring, just wondering if I was interested. And at that time, I was really happy at the VA. So I spoke with the chief of EP at Kaiser, but I, didn't really consider it at all. And then the next year, so after another year at the VA, I was kind of, I was still happy, but I was getting the sense that VA in particular, the nice thing about it compared to some place like Stanford or like a productivity-based place is that I definitely felt like I wasn't feeling pressured to do something because a referring cardiologist was asking me to do it. there's always that like slippery slope where I'm thinking, am I doing this pacemaker because I really think it'll benefit the patient? Or am I doing it because I don't want to lose referrals from this cardiologist? And you absolutely don't have to, think about that at the VA. But the flip side is that there's not a lot of incentive for physicians to be productive at a place like that, And I was kind of feeling that, the procedure volume wasn't great at the VA. I mean, I still got to work with fellows. And so the chief of EP at Kaiser called me again the next year because another EP was retiring earlier than expected and just asked if I was interested. So this time I talked to him a little bit more, looked more into the retirement benefits at Kaiser. That's one of the, I think, big sells that Kaiser has to recruit good physicians. And so ultimately I took the position at Kaiser and I moved here 3 years ago. And since being here, I'm also super happy. I feel like it's a great balance between Stanford and the VA. So in the sense that it is also not a productivity-based system. So I don't feel that pressure of, ooh, should I do this just to make that person happy so I don't lose their business? I can make decisions based on what I feel is, good for the patient and will benefit them. But unlike the VA, there are incentives at Kaiser to keep patients happy, to have accessibility in terms of getting your appointments on time, patient satisfaction, et cetera. And so, because Kaiser, wants to keep their patients. And so at least in, cardiology and EP, I don't know about the other departments, but I feel like even though we're not productivity based, everyone is just excellent in terms of their ethics, their work ethics. And I have great colleagues and they're like the role models. I look at them and I'm like, wow, that's great. So Kaiser and Santa Clara or Northern California EP is also kind of unique in that it is, I thought Stanford was very much specialized in EP, meaning that as an EP there, I didn't have to do general cardiology, which is true. But at Kaiser, it's even more so, if you can imagine, in the sense that it's a hub and spoke model where you have EP for the whole region, the whole Northern California region at Santa Clara mainly, and there's a couple of EPs at Sacramento. And then all the other Northern California Kaisers will refer into these two centers. So at Stanford, yes, I was only doing EP, but I was still seeing clinic patients and managing antiarrhythmics for AFib or VT, et cetera. At Kaiser, I don't even do all of that day-to-day medical management of arrhythmia. They really get referred just if they need a procedure or if it's a really complex arrhythmia question. And a lot of the local cardiologists end up doing most of the day-to-day arrhythmia management. And so you're really practicing at the pinnacle of your training and just in terms of doing lots of procedures. The procedure volume here is crazy, more so than Stanford. Just in the 3 years I've been here, I've seen cases that I never saw at Stanford. And so, yeah, for me, I feel like I've come home and this is where I was meant to be. So.
Wonderful. Thank you for sharing, Dr. Park. And next we have Dr. Aditya Bharadwaj.
Thank you, Panis, for that question. I myself have been in academia for the last 5 years of my practice, but I'm going to share some of my observations, and I'm sure the others on the call who have transitioned between academics to private practice will agree with me. I think now more than ever, the lines between academia and private practice are really blurring. And I say this because, how do you even define academia or private practice anymore? Is it the opportunity to teach fellows? Because a lot of private practice hospitals also have fellowship programs. Is it the opportunity to do research and publish? because a lot of large community hospitals run large randomized control trials, and a lot of people in private practice are prolific publishers, right? Or is it the compensation model? I can tell you that a lot of universities follow the RVU compensation model, like here at Loma Linda, it's productivity based. So how do you even distinguish between these two anymore, right? So I think Dr. Park touched upon it a little bit, and it's also previously been touched upon a little bit. I think what I would urge fellows to do is to really sort of think about what you want to do. I mean, broadly speaking, there are 5 categories of practice models. Okay, there is a 100% researcher who is mostly doing either basic science or translational research. I mean, those are mostly the MD, PhDs, or you need to have grants of your own. You need to be able to run animal labs and stuff like that. Then there's, of course, the physician scientist, which I think most of us would fall into that category, where you do some clinical work, you do mostly clinical research. Then there is a physician educator tract, where you take care of patients, but you also invest a lot in educating, in training residents and fellows and medical students. Then fourthly, there is the administrative hat. You want to be a physician administrator. I mean, you may or may not have a hospital administration degree, but that may be something that somebody wants to do. And fifthly, you may want to be a pure clinician. So I think that's what I would urge fellows or people, looking at their first job or even transitioning jobs should be thinking about. Because I think, in this day and age, more so now than ever, you really can't slot jobs into academic or private practice. I can also tell you that academic programs and universities are expanding. They're acquiring a lot of satellite hospitals, hospitals that are not directly, in the same geographic region as the university. And there are people that are hired to work exclusively at satellite hospitals where it's mostly clinical work. So I think it really boils down to you really can't, it's not as black and white. On the other hand, there's a lot of nuance. And I think, first of all, I think people looking for a job should decide for themselves what they want to do. And then, when they're signing that job contract, I think that really needs to be vetted as to what kind of opportunities they're going to have for teaching, for research, how much time they're going to spend clinically, are there any opportunities for administrative roles, those kind of things. So, that's my 2 cents on it.
Excellent. Thank you all so much for that. So we're going into the open Q&A session. So we've gotten a couple of questions from the audience as well. And if there are more questions, please feel free to either write Pani or myself or raise your hand, and we'd be more than happy to unmute you at this time. So one of the questions that we had gotten, and we've kind of touched upon briefly throughout the course of the night, is mentorship. And the question is, how would you choose a mentor? Like, what do you look for in a mentor, either going into cardiology or going into EP or interventional? So I don't know if, I know Dr. Hongo and, Dr. Han and Dr. Hoff had all spoken to this or touched upon it briefly. So if any of you want to join.
Sure, I guess I could say a few words about, if I think back at how I, developed a relationship with my mentor, it was like has been pointed out by other panelists. A lot of times it happens by chance. You don't plan for it. In my case, it was really sitting through a grand rounds. It was just kind of walking in, you're required to go to grand rounds, sit through, and coming out of there saying, wow, I didn't understand how, how mapping and so forth. So he showed all these, back then it was fairly primitive cardo mapping, but all the colors and everything I was looking at and saying, wow, this is a completely different thing. But what I think eventually drove that is immediately after that, I called him up and looked for an opportunity to spend time with him. And it really does come down to, I think, to develop a relationship, you need to spend time. And sometimes it's going to be spending time with several different people before you find someone who you can really relate with, but also find someone, in my case, that really took the time to invest in my career. And I think that's a key thing you need to find in a mentor is it's, of course, it's someone that you can relate with, who who's really someone that's in your specialty, in the direction that you want to go. But it's critical to find someone that will then really invest the time for you. And when you find that, I think you really get through the mentor relationship that can really alter the way your career goes. And so I remember the 6 months I spent up at UC during my third year here at CPMC. We spent days doing research, and at times they needed someone in the lab, so you pulled me into the lab. And so with that, I completely knew what direction I wanted to go to. But even today, I'm still calling Mel from time to time about whether it be cases or directions, decisions to make. And it's that sort of relationship that that really can shape your career, make it meaningful. Really helped me find what was important to me. Sometimes it happens fortuitously, like me walking into the grand rounds, but other times I do think it takes time and spending potentially time with different people until you find the person that really has your interests, has your career in mind. So finding that person, I think, makes all the difference.
Yeah, I would echo that. I mean, I think that a mentor is not someone who walks ahead of you to show you how they did it. It's someone who walks alongside you to show what you can do, right? And so that's not always easy to find. It may take you going through multiple different mentors and people to find that perfect fit, spending time with these people. But I mean, ultimately, it's about not just an experienced person, but a good person and someone that you resonate with. So I think just, being with your institution at national meetings, just interact with people, finding that person that you kind of resonate with. And because that's, besides obviously your program, finding good mentors, it'll change your whole career, And so, I mean, I think you spend time trying to find that person for you.
I can second that. And I think in my career, it's interesting. My mentor came into my life 10 years after I was in the institution. And I would just want to just give kind of overdue, like, thank you to Dr. Gary Milkman, who is my mentor now. But I think he was sort of in the background until maybe a couple of years ago when he realized that I was in the wrong place. And when he said, this is what you should do. And I think it's important to find a person, not necessarily interventionalist or not interventionalist, or somebody who, it could be a AP person. It's just a person who's going to make you better, who's going to make you feel like you're better than other people think you are, who's going to actually advance your career, not by like calling everybody, not like doing anything for you, but just kind of making you better. Like even now I can call him anytime. I can say, this is what I think, and he can totally disagree with me, and we argue, but it means that it's like arguing with yourself pretty much. Well, that's what mentor is. Like you're arguing with yourself. And then when you do something, and if I do it right, that's great. He's happy. If I don't do it right, he's unhappy, but he's unhappy with me. Right. So it's just like it's like your board that you can reflect off and helps you like make yourself better. I've actually never had like this sort of mentorship relationship until like this 2 years ago. I'm really thankful that he's around and he helps me. So.
Excellent. Thank you guys so much.
Yeah.
Wonderful. Thank you. I think our next question is also going to be open to the female panelists from one of the audience questions that we got. So, and this is a topic for both Megan and I, being women in cardiology, and myself starting fellowship with a newborn. It's a topic that is very near and dear to our hearts. But obviously in your procedural field, if our female panelists could comment on, what challenges you had to overcome as a woman in cardiology, and also specifically in the procedural field with radiation exposure and family planning, and any advice you may have for female fellows considering procedural fields.
Yes, I have 2 kids, and So the first thing in general I'll say is there's no perfect time to have kids. We are all type A personalities, and I know we want to try to plan, like, I'm going to have, they're going to be born on this day, and then I'm going to start fellowship on this day. It's never going to happen with pregnancy. You just cannot predict, right? So there's never the perfect time. And if you want to have kids, just try to have kids. And when it happens, you will figure something out. So that's just sort of the blanket statement. I think for me, it happened to work out because with my son, I was on a 2-year NRSA grant for my last year of cardiology fellowship, and then I had just a pure postdoc year, and I got pregnant that first year of the grant, and so he was about a year old when I started EP fellowship. And I didn't have to do any cases while I was pregnant with him, so I didn't even have to deal with that question that year for him. For my second child, my daughter, so again, I got pregnant right when I started attending. And I had already, I was trying to get pregnant towards the end of EP fellowship. And I had already made the decision that I was going to continue to do cases, even if I got pregnant, because as I forget who mentioned before, those first like 3 years or so, 2 or 3 years after fellowship are like really pivotal in terms of you just getting into your groove, establishing your style and your what your strengths are and all of that. And I knew if I was just not doing cases for 9 months, it just wasn't going to be very good for my procedural career. And so there's not a whole lot of data in terms of radiation exposure and long-term effects on the fetus or your baby. There's certain guidelines in terms of what the how many milligrams are considered okay during pregnancy, and so I basically just I double leaded, so I got a specific pregnancy lead just in the front around the belly, and then wore my normal lead over it, and then you get a fetal badge that you put, just on the fetal apron. And there's really, I guess I was kind of lucky. I was at an academic institution with these big fellows I could stand behind, and then a lot of times I could also just be in the control room, while the fellows were actually by the bedside. So I got to minimize, my fluoro exposure that way. And my daughter seems fine so far. She's just 7 years old, but I guess we'll see. And so I never regretted continuing to do procedures. As you get bigger towards the end of pregnancy, it's hard just physically carrying all that weight. But it's doable. I never felt like I couldn't do it or felt like I was endangering, my baby because of it. And to be honest, I actually say that after having my baby, you don't have to worry about radiation anymore, but just from the fatigue factor and pumping and all of that, trying to figure out when to pump, that was actually harder for me. I was just so fatigued from having a newborn, and then having to figure out like when you're gonna pump in between cases. And again, you do it. And for me, I knew I loved EP and I didn't want to do anything else. And kind of that got me through, those early years.
I think one thing that I'll say is that I think now compared to when I was going through fellowship, I think now we're so much better about sort of understanding that women do get pregnant and it does happen when it happens and you just have to work around it, right? Right now, my own fellow, EP fellow, one of them is pregnant. And, we basically said, what cases you want to do, what cases you don't want to do, it's fine, right? And I think people are more willing to do that. That's one thing. I know Shirley had already talked about the different types of leading and badges as well. But the one thing about EP that's really great, to be honest with you, is that the fluoro reduction that has happened, even over the course of my career, that I feel personally that it's a lot safer now. Even if you were worried back then, it should be even less worried now because of all of the 3D mapping and all that kind of stuff that we can do with ablations that we don't do stepping on fluoro like I did when I was a fellow, right? So many cases now can be done completely fluoroless. So I think that's one thing that if anyone is considering EP and how people say, oh my God, EP uses so much fluoro, that's probably not true anymore today. It's true now for a lot of, some device cases, and that's only because, we're doing a lot of CRT, we're moving towards left bundle pacing, which is even shorter, right? So I think nowadays, much less fluoro for EP.
Excellent. Well, thank you very much for that. Our next question has to do with the fact that a lot of our panelists are part of, national organizations, state organizations, as well as administration within their own institutions themselves. And the question is, how do they do that when, they are hard at work in the EP lab and the cath lab? How do they balance both responsibilities? And the second part to that question is how and when do they recommend fellows get involved in both national, state, and their own institution or organizations?
I can start, Megan. So I'm actually very actively involved with the ACC. I'm the early career representative for the state of California ACC, and I also sit on the Early Career Leadership Council of National ACC. And I think being a part of ACC or any sort of academic organization is something that I would recommend fellows and even early career attendings to start right from the get-go. There's really no reason to delay. And I think it's important to realize that these organizations are there to support you. They're there to give you all the resources that you need. They're a platform for all the things that we just talked about in terms of networking and mentorship and all the different ways in which they can help you. So in terms of balancing, the time between clinical work and being involved in organizations, I think that'll come easy the moment you're convinced that you want to be a part of an organization. Then it really doesn't seem like work anymore. Like everything else that we talked about, like whether it's taking call or whether it's working long hours, it doesn't seem stressful as long as you enjoy it. And I think, once you're convinced that you only stand to benefit by being part of these organizations, that's when you start enjoying it. And that's when it really doesn't seem stressful at all. So I think my word to fellows would be, make use of all the opportunities. I mean, ACC, Sky, they're all amazing organizations. They're here to support you. They're here to foster your growth. They're here to provide, inexhaustible educational materials. So use all of it and get involved as soon as possible.
Fantastic.
I can speak briefly to that as well. I couldn't agree with you more, Aditya. I think, when you look at your career, it is a 20 to 30 year marathon, right? And so as a fellow, you look at us attendings and, you see a lot of attendings with burnout problems, right? It's been highlighted in many of our journals. So the question is, how do you avoid burnout? And I think that it sort of dovetails with complacency. I mean, complacency is sort of the kiss of death, right? For any of us cardiologists. None of us want to be that old cardiologist who's not in touch with the data anymore. And so I think that being a part of a national organization allows you to be on top of the data more so than not being a part of the organization. It also gives you a source of pride, a source of joy and meaning. Honestly, we sort of emphasize that at Kaiser, which I love about Kaiser. And I think another piece. So if you look at everything that we do, a lot of it is formulaic, right? So whether it's even EP or interventional, there's some procedures that after a while they become sort of routine. So the question is, how do we make these things interesting to us? How do we engage ourselves and keep it enjoyable? One is to look at things that change over time, and that is patients, right? Our patients are different every single time. So if we engage with our patients, try to get to know them a little bit better, it actually increases your joy, right, in practicing medicine. And the same applies to data. Data is constantly evolving. If you're in touch with data, it keeps you engaged and not burnt out. So in my view, and this is advice to me too, I'm advising myself as I say this, because all of us suffer through periods of burnout and periods where we're more engaged with our jobs. And if we recognize that we're in this for the long haul, we have to focus on the variables that are going to give us joy and meaning. And two of those variables in my mind are data and keeping up with the data and just maintaining a connection with our patients. So that's my advice.
Great, thank you. Very well said, Gopi. We appreciate it. I think you bring us to our next question that I think is a very important topic given your guys' proceduralist fields, is the question of work-life balance. I think you guys all touched on this, but if you could elaborate on what you actually do to specifically maintain a good work-life balance, and also how you are able to continue focusing on your wellness and avoiding burnout.
Yeah, I think medicine, especially, really all aspects of medicine, I think from day one, you're always going to have a constant sense of I'm not doing enough. I should be doing more. I'm behind. So you need to always take time to foster your life outside of medicine. You need to, constantly be evaluating that and taking time to build that. You know what I mean? Like you guys were talking about with the women in cardiology. I mean, there's no good time to have a baby. There's not, you have to, spend time, in these other areas. So I think that always know that feeling, we're all type A, we all want to be the best, and so no matter how much you do in medicine, how top of everything, you're always going to feel like, oh, I need to be doing more. I need to be doing, this committee, that committee, this, all these kind of things. So, just being conscious of that and aware of those feelings, but, you need to take care of your life too, because otherwise, no matter, you're going to burn out, so you need to just spend time with your life outside of medicine.
I agree. And I would like to second what Jason said and just make one more comment on this. I completely agree with finding that activity that gives you just unadulterated joy. I mean, it could be playing with your 3-year-old, or it could be going on a hike, or it could be going to the gym and working out. But whatever it is that, gives you time for yourself, when you're not thinking about medicine and all the different things, absolutely invest in that. Even if it's just for 30 minutes a day, I think that's absolutely essential to invest on it. And the second thing is something that I learned pretty early. Multitasking is a myth. Okay, so I think you have to be in that moment at that time and give your 100% to it. When you're at work, do not think about your kids. And when you're playing with your kids, do not think about that paper deadline that you have. Be in that moment, give 100%, and move on to the next activity without any guilt. I think that's very, very important to master that art. And then you will find yourself being able to squeeze a lot more into your day the moment you stop trying to multitask.
I second that. Multitasking, that's the kiss of death when you try to do everything at one time. And I wasn't going to say anything during this work-life balance because I do not have work-life balance. I think Anna can attest to that, right? And Jason, I have 4 kids as well, and I have the most understanding wife as well as family. And I need to do more. And like you said, you just have to make the decision. And, I'm thinking about this now, which is, 18 years into my career, hopefully isn't too late. But I would urge, all of you that are starting off your careers to hear what the other panelists have been saying. You have to make this decision to say, I'm going to put aside time to do this. Yeah. Not to multitask, but like you said, the best days are when you wake up and you love driving to work, but then you love getting in your car and driving home. I mean, those are the best days. And so if you can find a career that balances that, I think that's when you start having balance. I'm working at it, so I can't say I have it, but I very much understand the importance of it. And I'm coming to it a little late because it's the workaholic I am. But But I think all of you should start thinking about that probably from day one when you start your careers.
That's 100%. I will add on to what Richard just said to say that work is always going to be there. It's never going to go away. You will always be behind. It's just the way that it is. But the issue is your kids, your husband, your wife, your partner, your friends, they may not always be there, right? And I think that's the thing. It's those key moments in time that you have to take. And it's okay to say no to work. And you will regret when you say no to your family or your friends or whoever it is that's important in your life.
Yeah. And for me also, I think it's also important to have partners that understand that, and the partners that actually do not call you when they know you're off and only call you when it's important. And I didn't think it was important because I wanted to be called all the time. Like I want to know, but many of my partners, right, in where I am right now, they would call and say, I hope you're exercising. I hope you're running. I hope you're doing everything because the recharge is so important, because the life part of it, the balance is important, that you recharge. So when you come back, you don't look like you don't want to do anything. So that you come back full of energy, you want to do it again and again and again. And if you don't recharge, it's impossible. Because you can't be like Rick Hongo, perpetual mobile all the time. Nobody can do that.
No, I think of multitasking also as, having your phone and stuff. So when I'm gone, I try not to answer. And when Steve's covering, I just let him cover. That part I'm okay with. It's just, I have to choose to be at home and see my family more. I definitely need to do that more.
Yeah, you kind of, at the end of the day, that's where you don't regret doing less procedures, you regret being at home less. That's what I realize as I move on.
Yeah, exactly what Janet said, yeah.
Yeah, I think a key is the idea of, not multitasking. And when you're at home, you focus on your home life. And then that way, so if you are spending, it's not so much the quantity, but the quality of time that you're spending with your kids. Like you could spend half an hour doing something really great with your kids, and they're going to feel like it's, 2 hours because they're having such a great time with you. But in that sense, even if you only have half an hour, you can make a lot out of it if you focus completely on your family at that time. So like my daughter is very much a mama's girl. She's always like, when are you coming home? And are you gonna be here in the morning when I wake up? And so what a lot of times I'm not. So what I'll do, what we set up is on Saturdays we have movie night, just her and me, where we there's like a sofa bed in our rec room. And so we'll, eat dinner and watch a movie together and sleep together in that bed as if it's like a slumber party. And, I said, it's only when I'm not on call. And so she understands that. But so, at least having that regular event that's just her and me, it makes it special. Even though it's really not that much time, it's just one evening a week. So little things like that.
That's excellent. All very well said. So our last question for the evening comes again from our audience, and this audience member is curious how the panelists work with industry, as it's common to see reps in the lab. Anyone of the panelists ever done consulting?
Yes, I do consulting for Abiomed and CSI, and I think being proceduralists, whether we like it or not, I mean, we have a very symbiotic relationship with the industry, and it's we learn from them, they learn from us. They make tools that we can use to help patients. So our involvement with them, our feedback to them, our ability to participate in research, the trials that they run is extremely important, to not just answer important scientific questions, but also to improve the device, to improve the technology. So I think there's definitely no harm. I look at it as a way I can advance science and help my patients, honestly.
I agree. I think there needs, especially, I can't speak for intervention because obviously that's not what I'm, the field that I'm in. But like it has been pointed out, EP is a very device, technology, and a healthy relationship, I think, with industry, for me has been very important, whether it be trials or also speaking for them, but also being involved in different new products and so forth, and understanding where they fit into practice. I think there's a line you have to personally kind of decide where that's going to be in terms of involvement, but to totally shut it out, I think you lose a part of being in a field that is very technology driven, innovation driven, and that relationship can be very fruitful, but also very stimulating.
Yeah, I've been involved in a few like panel discussions for the drugs or for like the anticoagulation in the interventional field, and I told at the end, like, do not need to pay me for this, because it was just so intellectually stimulating to hear a lot of people who actually drive there's a lot of people who participate there. One of the persons was the Augustus trial, right, investigator. He knew how the whole Augustus trial was built and based. He knew every in and out of the trial. I would have never learned that from any article. So I'm like, every time they invite me, I'm so grateful to be part of it. And I always say I don't need to be paid. I just want to be part of this discussion and hear it. So it's important to kind of have that relationship with industry, and also in the lab. I'm happy when they come in and help with devices, or they're there, because a lot of times they'll go to different labs and they'll bring a lot of different experiences into your lab. So it hasn't been a bothersome for me at all experience.
All right, wonderful. Thank you all so much. I think that brings our program to a close for tonight. It's been an absolute pleasure spending the last hour and a half with you all. So again, we'd like to thank our wonderful panelists for their time, amazing advice, and valuable pearls. We'd also like to thank the California ACC Executive Committee for the opportunity to provide fellows and residents with this tremendous resource. And lastly, we'd like to thank all of our guests for joining our session tonight.
Yes, I'd like to echo Pani about that, and just remind our audience that the session is recorded and will be available for your viewing on the California ACC FIT website. Please make sure to join us again tomorrow for our next great session on heart failure and critical care, or cardiac critical care to be more exact. And we look forward to seeing you all then. Have a good evening.
Thank you, everyone. Take care.
Thank you.
Thanks, Megan. Thanks, Pani.
Thanks.
Thanks, guys.